Our agenda for today. We will make a rapid, brief review over acne vulgaris and its effect on quality of life, acne scars, acne scar management, in vivo imaging of the skin with special emphasis on optical coherence tomography and our split face study. As we know, acne vulgaris is a chronic skin inflammatory condition characterized by polymorphic lesion between open comedones and plaque comedones, closed comedones, inflammatory lesions like papules and pustules, nodules with various degree of scarring. Acne vulgaris is by far the most prevalent skin disorder, affecting about 90% of adolescent and young adults. Despite availability of various topical and systemic treatment, still scarring is a common outcome. Acne is known to negatively affect the quality of life. World Health Organization, WHO, declared acne that it can cause disability or result in residual disability, and it should therefore be considered a serious illness that affects the productivity of society. Acne scars results from abnormal wound healing process or resolution after injury that happens in the sebaceous gland through inflammation of acne, which typically proceeds through wound healing phases, as we previously mentioned, inflammation, granulation, and remodeling. Severe acne scarring is reported in about 30% of acne patients, although mild to moderate scarring have been reported up to 90% of these patients. Acne scars can be categorized as either loss of local tissue or increased local tissue formation. They include boxcar scar, ice pick scar, rolling scars, hypertrophic or colloidal scars. Acne scars and the quality of life. The determinal effects of acne scarring are not limited to impaired cosmetic appearance. Rather, acne scarring has also been associated with depression, other mental health disorders, suicidal ideation, emotional debilitation, imprisonment, poor self-esteem, and general social impairment. Acne scar management. A plethora of treatment options have been resulted from the need to treat various acne scar types between laser therapy, radiofrequency, microneedling, chemical peels, surgical techniques between punch grafting, subcision, excisions, injection of dermal fillers, autologous fat transfer, and dermabrasion. But unfortunately, acne scars present a therapeutic challenge with no known modality can consistently offer satisfactory result. And still, there is a lack of consistent guidelines on treatment or combination therapies for various clinical scenarios. Here, still, acne scars and the acne scar management is a still point of research and still ongoing studies and clinical trials on this topic. And the ongoing clinical research have noted that there is a variable response in various skin types, with the trend increasing using minimally invasive techniques, and this highlights fractional technologies. Fractional technologies, either laser or fractional radiofrequency. Fractional technologies can achieve very good results with minimal side effects and downtime. Fractional lasers create column of microthermal treatment zones surrounded by healthy unaffected tissue, resulting in rapid healing times and lower risk of side effects. On emphasis of erbium-YAG ablative laser, which targets the water chromophores in our skin. It ablates the superficial layer of the skin and can be used for superficial tissue ablation with the advantage of quick healing, low degree of erythema, and low post-operative morbidity. Regarding fractional radiofrequency are a relatively new modality to treat acne scars, as Dr. Mona have discussed earlier. It uses electrodes to deliver electric current into the skin, generating thermal energy, causing dermal remodeling. This results in skin rejuvenation, low downtime, and minimal risk and complication. Fractional technologies know till now studies that compare fractional lasers with fractional microneedling radiofrequency. There is many papers that discuss each of them alone. So in this context, we decided to conduct a study that compared fractional erbium lag laser with fractional microneedling radiofrequency in acne scarring. And besides using an objective technique for assessment, which is optical coherence tomography, to ensure accurate results. Why optical coherence tomography in particular? In vivo scan images includes about 5 devices between confocal microscopy, high frequency ultrasound, computed tomography, MRI, and optical coherence tomography. And this table shows maximal depth of penetration of each of them and maximal resolution for each of these devices. As also, these diagrams shows the confocal microscopy only shows epidermis. Optical coherence tomography can give us a picture up to the dermis. High frequency ultrasound can give up to the muscles. MRI and CT can show up to the bone. But however, CT, MRI, high frequency ultrasound have penetration depths, but at the expense of reduced resolution, they give low resolution images. Conversely, confocal microscopy have high resolution at much lower penetration depths. OCT can image deep tissues than confocal microscopy while maintaining resolution exceeding those of CT, MRI, and ultrasound. Accordingly, we have a choice of using optical coherence tomography. As we can see, this is a diagram about a photo that optical coherence tomography gives. We can see epidermal layer, we can see dermis, we can see the stratum corneum, even the adnexal structures of the skin and the blood vessels. This is our study that we conducted, the study under the title of a split-phase comparative study of fractional erbium YAG laser versus microneedling radiofrequency in treatment of atrophic acne scars using optical coherence tomography for assessment. Our patients and methods, our study design was randomized, controlled, split-blinded, single-blinded, split-phase clinical trial. We included about 21 participants in our study. Complete history was taken. Examination including assessment of acne scars, severity of acne scars, grading of acne scars according to global acne scarring classification. Included also self-assessment of the patient using scars questionnaire and the facial acne scar quality of life. We have did photographic documentation using a professional camera, and we have used OCT assessment at baseline and about 3 months after the last session. Also, we have focus on side effects assessment. We assess the pain sensation, post-treatment heat sensation, and patient satisfaction. Our patient received 4 sessions on monthly basis. We have randomized the patient to receive fractional erbium YAG on one side of the face and the fractional microneedling radiofrequency on the other side. We used the Photona erbium YAG laser and used the Vivace microneedling radiofrequency device. We have documented the photos at baseline, before session, after session, immediately, 3 days post-session to assess side effects, and 3 months after the last session, beside OCT assessment at baseline and 3 months after the last session. Our result came to the conclusion that acne scar grading was significantly improved with both sides, fractional erbium YAG laser side and fractional microneedling radiofrequency side, and there was significant reduction in acne scars grade in both sides, but without significant difference between both modalities. Regarding physician global assessment, the mean percentage of improvement on radiofrequency side was about 80 to 90%. However, it was only 82 to 84% on the laser side. Regarding patient satisfaction, 81% of our participants were more satisfied with microneedling radiofrequency side, and only 61% were satisfied with erbium YAG laser side. Regarding the improvement of epidermal thickness based on OCT imaging, Each modality per se resulted in a statistically significant increase in epidermal thickness post-session, with the difference being insignificant but in the favor of fractional erbium YAG laser. We concluded that laser increased epidermal thickness more than fractional microneedling radiofrequency side. As we can see from the graph, the first graph on red and blue shows epidermal thickness improvement compared between basal line and post sessions. The graph in purple and green shows a change in epidermal thickness between microneedling radiofrequency and laser, with the favor on laser side. Regarding improvement in dermal thickness based on OCT imaging, both modalities resulted in a statistically significant increase in dermal thickness post-session, with the difference being statistically insignificant but in the favor of microneedling radiofrequency device. Microneedling improved the dermal thickness more than laser side. As also shown in the graph on the left shows a difference between baseline and post sessions. The graph on the right shows an improvement of dermal thickness between microneedling and laser side. On correlation between the result and demographic data, none of these clinical demographic data, age and sex and family history, oral isotretinoin intake, and acne scar duration influenced increase in epidermal thickness. However, on correlation between dermal thickness increase and demographic data, it showed that in 6 showed statistically significant difference in the dermal response to fractional erbium YAG laser, with more increased the dermal thickness in males. Males showed increased dermal thickness more than females. History of oral isotretinoin intake decreased dermal response to some extent. However, this needs further research. On correlation of dermal thickness on the microneedling radiofrequency side, the same result was concluded. In dermal thickness increased more in males, and isotretinoin decreased dermal response to some extent. Regarding self-assessment scores, self-assessment of acne scar grading, scars questionnaire pre and post sessions reveal significant reduction of self-assessment of acne scar severity, and also quality of life questionnaire pre and post session reveals significant improvement of psychological and social well-being. Photos of our patient. This is a 23-year-old female patient with significant clinical improvement. The orange color is for the fractional microneedling radiofrequency side. Upper photos for pre-session baseline, and lower photos for after sessions. We can see improvement in grading of acne scars, Goodman-Barron score from 18 to 7, and on the other side from 21 to 10. OCT images shows that in dermal thickness before starting of sessions was 77 micrometer, increased to 87 micrometer post sessions. Dermal thickness was 381, increased to 398 micrometer post sessions on the microneedling radiofrequency side, which means significant improvement. Regarding the laser side, epidermal thickness was only 73 micrometer, increased to 81 micrometer post sessions. Dermal thickness was 361 micrometers, that increased to 380 micrometer post session, which means significant improvement. Patient 2, 38-year-old male with significant clinical improvement of acne scars. Goodman-Barron score regarding acne scar grading was 22 pre-sessions reduced to 16 post-sessions. On the other side, it was 20 pre-sessions that reduced to 16 post-sessions. Regarding OCT images, epidermal thickness was 110 micrometer pre-sessions that increased to 121 micrometer post-sessions on the microneedling radiofrequency side. Similarly, dermal thickness was 458 micrometers, that increased to 505 micrometer post-sessions, which means significant improvement. On the laser side, epidermal thickness was 100 micrometers, that increased to 110 micrometer post-sessions. Dermal thickness was 468 micrometers, that is increased to 517 micrometer post sessions, which means significant improvement. Adverse effect. Regarding evaluation of adverse effect, scaling or escapes, laser caused scales, but microneedling radiofrequency caused only minimal escapes that last for from 1 to 3 days only. However, laser, as we all know, caused scaling that lasted for about 1 week. Regarding pain sensation, fractional microneedling radiofrequency caused severe pain during the session and only mild or nil after immediately we stopped the session. Laser caused mild pain during the session, which increased to be severe after sessions. Heat sensation, regarding microneedling radiofrequency, it was nearly nil. However, with laser, it is rated to be about 3, severe heat sensation. Duration of erythema, just hours, lasted for hours with microneedling radiofrequency and lasted with 1 to 2 days with laser side. Other adverse effects reported with our participant, 5 participants experienced transient folliculitis on the microneedling radiofrequency side. About 3 participants experienced increased erythema, eczematization, and post-inflammatory hyperpigmentation on the laser side. We came to the conclusion that in both ablative laser and fractional microneedling radiofrequency are effective in acne scar treatment. OCT confirmed the skin anatomy improvement which wasn't statistically different between both sides. Both treatments are well tolerated. However, fractional microneedling radiofrequency has more safety profile and more rapid return to lifestyle activities. Selection of modality of acne scar management depends only mainly on patient lifestyle and skin type. Thank you.
شكرا جزيلا.
شكرا دكتورة أميرة. هو بس احنا يعني عشان الناس اللي ما كانتش منتبهه قوي، احنا يمكن دايما بنتسال الدكتور ماجد اكيد، طب الفراكشنال ليزر احسن ولا المايكرو نيدلينج احسن ولا الفراكشنال راديو فريكونسي مايكرو نيدلينج؟ فالاستاذ دي احنا عاملينها عندنا في الجامعه، عملنا سبليت فيس، وان سايد فراكشنال ليزر وان سايد فراكشنال راديو فريكونسي. زي ما احنا شفنا كلينيكالي ما فيش ديفرنس بين الاثنين، بس الساتسفاكشن بتاع البيشنتس كان احسن مع الفراكشنال راديو فريكونسي. الاو سي تي طبعا طلع ان الابيديرمال افكت بتاع الليزر احسن كتير، يعني الابيديرمال لان احنا اتفقنا ان الفراكشنال راديو فريكونسي كل الافكت بتاعه ديرمال، فالفراكشنال ليزر ساعد ان هو يحسن الابيديرمال سيكنس، لكن الراديو فريكونسي لا. لكن الفراكشنال راديو فريكونسي احسن في الديرمال، بيزود الديرمال سيكنينج احسن من الفراكشنال ليزر، بس يمكن كان في النهايه الساتسفاكشن بتاع العيان كان اكتر مع الفراكشنال راديو فريكونسي، ودي يمكن الحاجه نعم عشان الداون تايم. يعني هي دي فعلا احنا يعني في صاني اريا ومعظمنا ستودنتس والسكين تايب بتاعنا مش مناسب، فاحنا فوجئنا ان الناس ساتيسفايد بالراديو فريكونسي اكتر من الليزر. كل السكين تايبس.
شكرا جزيلا دكتورة أميرة على البرزنتيشن الرائع. طبعا